Thank you for inviting me. I'm going to talk a bit about the role of monoclonal antibodies and the challenges in prevention and treatment of infectious diseases in children. The monoclonal antibody production in the lab just turned 50 years this year, as this paper in Nature mentions, and it's got a big part of the pie of the market size in drugs, accounting for $500 billion. And they have actually revolutionized the treatment of non-communicable diseases, especially in rheumatology and other, but also show important promise for infectious diseases. You have high levels from the very beginning compared to vaccines, for example. They're very specific in binding the microorganisms. They have a very good safety profile, rapid speed of discovery, and a unique role in vulnerable populations as children. So there is a number of antibodies already developed or in development for infections, including HIV, RSV, COVID, Ebola, Clostridium, anthrax, malaria. I'm going to only talk a little bit about HIV and RSV. And we're going directly to understand what are broadly neutralizing antibodies. Broadly neutralizing means that these antibodies are able to neutralize several strains of HIV, although within one specific patient who actually has BNAbs, there may be other viruses that evolve and have mutations and escape from these BNAbs. They are produced after years of infection by a minority of patients, and there's two concepts that probably you know that, but it's important to understand very well, which is breadth and potency. The breadth is the percentage of strains that virus is capable of neutralize in a specific panel, and the potency is related with the IC50 or IC80. So how many of those viruses is able to neutralize at low concentrations? Usually, these IC50 or IC80 are measured in vitro, in the lab, but we will talk a little bit about that later. So they are directed against the protein trimer in the envelope of GB120, but these trimers have the domains usually quite covered by a sugar coat of glycans, which would be that green coat. And so it's not easy sometimes to target these epitopes. Some of those epitopes have already been described. The most relevant for actually for the BNAbs that are in the market are the CD4 binding site, the V3 glycan. I'm gonna check if I can use this. Not very well. Okay, the V3 glycan and the V1, V2 glycan. So what do? They neutralize the virus, as their name says, but they also enhance an effector function via ADCC, ADCP, they also via the complement and opsonization, and they also enhance both the immune system, NK, and dendritic cells, and apparently also the CD8 cytotoxic effect specific. And they also do something interesting, which is the tethering. They're capable of joining together different variants, different virus, and these virus cannot infect other cells. They have been used for mainly three purposes: prevention, treatment, and cure, or are investigated for that. So the prevention is based on the AMP trials, the HVTN 704. In this trial, the patients that were in the arm of the BNAB, which is VRC001, acquired less infections than the participants who were in the placebo arm. And especially those who were sensitive to the virus, which are the left part of the graph, which means that at low concentrations, these viruses were sensitive to the virus. Sorry, to the BNAB. So for treatment, in general, the trials have demonstrated that one dose of BNAB can reduce 1 to 2.6 logs. And also, they have demonstrated that the patients, specifically children in the Tagarro trial, can be suppressed for a long time without oral antiretrovirals. You can see this is from N6LS, that different patients that reduce the viral load after administration, and this one is from the Tagarro trial. As you can see, 44% of the participants of the children remained suppressed only on a combination of two BNABs without antiretrovirals. They are also intended for cure. They have shown to delay the rebound during analytical treatment interruption, especially in the Rio trial presented this year in the CROI conference, and reduction in the intact proviral reservoir, again demonstrated in the Rio trial and in some papers from Gabler and collaborators. This is the decrease in the Rio trial of the reservoir. And here you can see in the Gabler trial that also the intact provirus reduced after treatment. And for cure also, they have shown that they are able to increase the specific CD8 response. This is from the Rio trial again, and in other papers from Rosa-Sumbert and Niesel, they showed also with different BNABs to increase the CD8 response. As you can see, both also with staining the cytokines. There is, as you can see, a lot of studies and trials in adults. In children, we only have a few. With solid results, we have the Tagarro trial, which I just mentioned. And we have also some very interesting data from safety and PK from the impact network, as you can see, from VRC01, VRC07. And ongoing, there is, well, we just in the AAS Congress, we also learned that a combination of VRC07, FAT23LS, and CAP256 were safe, and there was some PK data. And there's other trials in enrolling, like Tagarro Plus, and in development, there's quite a lot, and I would like to talk about the trial that we are starting, hopefully in the next months, which is called Enable. In this trial, we are having two arms. One would be the standard of care with oral antiretrovirals for children less than 6 months who are diagnosed with HIV, and the intervention arm is standard of care plus two subcutaneous broadly neutralizing antibodies. One would be against the CD4 binding protein, and the other one is EPGT 1-to-1 V1LS. And the endpoint is virological suppression, and secondary endpoints would be adverse events, morbid mortality, correlation with biomarkers, ADCC, reservoir, and immune enhancement. So, how much of these BNABs should we give, and how often? This depends largely in a lot of variables, actually. In the potency, IC50 or IC80, which lead us to serum target, the breadth, the half-life. If we are giving them IV or subcutaneous, because the lymph flow is less than 1% of the blood flow, the HIV status, if the patient is viremic or not viremic, the age, the volume distribution, clearance, and growth. And I will talk a little bit about some of them. The volume of distribution of these bNAbs is typically small, and they are not metabolized by the standard enzymes, but they have a different mechanism of clearance via proteolysis with lysosomal recycling. They are internalized in the cells, and they are degraded at an acidic pH. However, there is a situation in which they are not degraded, but they are returned to the circulation, and this is when they bind to the Fc neonatal receptor. So when they bind to it, they are like they're, let's say, saved from degradation, and they are recycled into the circulation. This recycling can be enhanced by introducing mutations in the Fc domain, and we will see that in one moment. There's additional clearance mechanism as anti-drug antibodies, but in some of the trials, these antibodies haven't shown actual reduction in the effect. So in this paper from 2014, you can see that the bNAb, when a methionine is substituted by a leucine and asparagine by serine, increase the concentrations and the half-life. And this has been done consistently in all the bNAbs to increase the half-life, which is typically from 2 to 3 weeks until 6 to 7 weeks. Here we have an example from the impact network. In dark blue, you can see, in pink you can see the VRC01, and when you add the LS mutation, as you can see in light blue, the half-life is increased. Again, with N6LS, if you look into the red and into the blue lines, you can see that in this case, the way of administration provides different profiles. The subcutaneous administration provides a 40% viability compared to intravenous. But in general, the half-life of this LS formulation is around 48 days. The intravenous or subcutaneous administration also has an influence in the breadth. In these graphs, you can see that the same dose given intravenous or subcutaneous has an effect in how many strains of a panel are neutralized by the drug. Also, as you can see, the HIV status in the left, non-infected or people without HIV, and in the right, people with HIV. The half-life is decreased in people with HIV, both for the 1074 and for the VRC01. And what about children? You know that infants can duplicate their weight in the first 6 months of life. This growth and also the increase in metabolism, these combined effects make that the clearance is faster in children. As you can see in this graph, in the dashed line, in adults, the bNAb has a longer half-life compared to infants. And this has been again demonstrated in the impact trials. As you can see, the adults, they have a longer half-life compared to infants. So that's why we need also modeling. This is a table which the results are very likely fake, because it was there was artificially intelligence generated with very quickly with ChatGPT. So don't take it for for actual. But you can see with they have different half-life, different doses, different administration, different targets. So the assumption led that the intervals that we have to provide these bNAbs differ between one and another. In the PEDMAT trial, as I mentioned previously, that we was presented just a couple of months ago in the AAS Congress, 2 of these bNAbs were tested together. And if we take as a target 1 micrograms per milliliter, which is quite common for bNAbs, we could provide them every 18 weeks. But if we provide it, if we are aiming for 10 micrograms per milliliter, we are only in a safe place if we provide them by 12 weeks. And why I'm asking, or why I'm wondering about 1 or 10 micrograms per milliliter? Well, that leads us to the concept of PD80, which is how many times we should have the concentration in the serum compared to the IC80 we have in the lab. And this is a little bit maybe disappointing, because as you can see, for example, in this graph, to achieve 80% neutralization in the lab, we may need many times more in vivo. In the AMP, again, the AMP investigators from the AMP trials showed that we may need up to 200 times the IC80 in the lab compared to the serum, or the other way around. So we would need to have 200-fold the in vitro IC80 to prevent 90% of infections in a specific panel. And this is important, of course, because it relates to the dose that we have to provide. And this is also important in children because it relates with the volume. You cannot provide 200 milliliters of volume to a neonate, so you have to be careful about that. But look, this is for prevention of a single antibody. But when we do combinations, this efficacy in prevention can grow up from maybe a 7% to a 95% in triple combinations. So the global diversity of virus and the bNAbs resistance mutations and the within host diversity, they all lead us to that we need to provide at the moment the bNAbs always in combination with other bNAbs or with other drugs, small molecules. Actually, the complementarity between different bNAbs improves the breadth and the potency. So we have some challenge with bNAbs. One is the viral resistance. Of course, there's resistance to bNAbs previous to the administration and after the administration. So to solve that, we go to combinations with other bNAbs, with antiretrovirals or multi-specific bNAbs. We also want to target the viral reservoir. For that, we will need latency reversal agents or other strategies. And to increase the antibody half-life and decay, we have already the LS mutations, but also there is very appealing approaches as the genic therapy. There's a team in Florida who is developing an adeno-associated virus who can introduce the genome in the muscle and then for the moment, the non-human primates start producing by themselves for months the bNAbs with only one shot. So that's really interesting. So who can access and how can access to bNAbs? Well, there are a number of bNAbs that are produced by the NIH, or also some companies, also IAVI, which is a foundation. But for some reason, it's been a little bit difficult to access the bNAbs from the NIH. And well, for the moment, I will stop here for HIV. And let me spend just a couple of minutes talking about monoclonal antibodies for RSV prevention. You know that RSV, it's a serious virus for children, for infants. The RSV can cause bronchiolitis, pneumonia, and in upper income countries, it's not, I mean, it's important, but it's mostly important in lower middle income countries where it causes actual mortality, is the second cause of mortality. And in the last years, we have a new kid on the block, which is nirsevimab, which has a half-life of 150 days. Formerly, the research was focused in the post-fusion RSV protein, but in the last years, the researchers discovered that the prefusion RSV, the prefusion protein, gets a configuration in which exposed a domain with a very high neutralizing potency. So this bNAb was directed against this domain and achieved very good results in the trials with more than 70% prevention of infection, hospitalization, and severe disease. So it's currently approved, and actually it's used in many countries with for children with less than 1 year, with all children born with within the RSV season, and also with a catch-up of children born before the season, and it protects for 5 to 6 months. The experience post-implementation in Spain has been great. The lines are the hospitalizations in the previous years, and the columns are the hospitalization in the first season after the implementation. As you can see, there is a huge impact, and this has been achieved thanks to early engagement with industry, which provided access, with universal healthcare, and this drug is paid by the regional governments, a proactive campaign at birth to all the parents, and phone reminders for catch-up for all the children who were born from April to September. And the real-world evidence showed even better numbers than the trials. This doesn't happen very often, but looks like that. More than 80% reduction in hospitalization, in very severe disease, PICU admissions, etc. So there's some challenges, which is access without public health care, the cost, which we know it has been moving from $200 to $1,200 in different countries, and this is far from the $5 that is considered to be cost-effective in lower income countries. Although the upscaling of production of bNAbs has been calculated that can be as low as $10 per gram. There's no real competitors yet. Also, clesrovimab is in the pipeline and it's going to be available soon. And the vaccine also has been already implemented. But probably we will need in the future biosimilars. The supply is limited and geographically concentrated. And in lower middle income countries, the regulatory processes are being slow, and the implementation has also some challenges, but it can be applied similar to vaccines. Well, there may be some scientific challenges, as this is in other children, which is still quite nasty in children from 1 year. But those who are less than 6 months, we are now almost free of them. there might be theoretically an escape. For the moment, we haven't seen that. And sure, it has an effect in epidemiology, which can be an opportunity also for multi-specific BNAbs. So that's it for the moment. Thank you very much, and I'm open to questions.